If a patient comes in, she's complaining of pressure, you do a speculum exam, and you see membranes ballooning out at you. The reason why it's called hourglassing is because on an ultrasound, you'll see the bag of membranes, goes through the cervix, and then the bag inside the uterus, and it's shaped like an hourglass. However, usually the the presentation is usually less obvious than that. Patient comes in with mild cramping, some bleeding, some pressure, maybe has a P-promd, the early rupture of membranes. And so what it's classically described now is that there's a spectrum between preterm labor on one side, incompetent cervix on the other side. And then the patient, it probably exists somewhere along this spectrum rather than just being one or the other. So when we think about that, preterm labor, well, that's exactly what it sounds like. It's labor that is preterm. It's painful contractions that causes the cervix to dilate. So an incompetent cervix doesn't need the painful contractions to dilate. It's somehow inherently weak. And so you have to take the clinical history, listen to the patient, look back at the last few visits and try to figure out where in this spectrum does this patient lie. Does she lean more towards incompetent cervix, or is this more towards a preterm labor picture? All right, treatment for incompetent cervix is basically we have to individualize this to the patient. If the patient is pre-viable, and by definition that's about 24 weeks, depends on your particular NICU, neonatal intensive care unit. Some will go down to 23 weeks fairly reliably. Some actually kick it up to 25 weeks. Some places, if you're in a remote area where you don't have that level of care, it's probably 28 weeks. But if we're pre-viable, immediately do bed rest. Trendelenburg positioning, so basically you're standing the patient on their head just a little bit. Use of a rescue cerclage, which we'll talk about a little bit, but that's a stitch that you put into the cervix to try to sew it shut. Or expectant management to allow the patient to deliver since she's so remote from delivery. If the baby is viable, greater than or equal to 24 weeks, we administer steroids, which helps accelerate the baby's lung maturity as well as stability of the brain. We may add tocolysis, which are medicines to help stop contractions. And then less often, if the baby's viable, will we use a rescue cerclage. Sometimes we will. It'll depend on the clinical situation. Now, cerclage is a stitch that circles the cervix to hold it closed. Now, various different types of sutures are used, and several different techniques exist. These are the McDonald, which is where you place the stitch at the cervicovaginal junction, the Sherrard-Carr, and that's where you actually do some dissection and place the stitch higher up at the internal os of the cervix, or abdominal cerclage. And that's where actually there's no or not enough cervix in the vagina to actually put a stitch around, so you go through abdominally and place it. Ideally, you're going to place these at 12 to 14 weeks of gestational age in a preventative manner. It is much better and much more effective to place cerclages preventatively than to place a rescue cerclage or as a treatment. So ideally, cerclages are placed in patients who have had risk factors or in patients who have had a diagnosis of incompetent cervix previously made. You'll remove the cerclage at about 36 to 38 weeks, doing it vaginally with the McDonald and Sherrard-Carr. Now, an abdominal cerclage, you'll actually have to do a C-section and remove it at that time. So if we remove the typical cerclage at 36 to 38 weeks and then allow the patient to hopefully deliver vaginally. Our next topic will be recurrent pregnancy loss. And this is defined as 3 or more miscarriages. Now, less than 1% of women have recurrent pregnancy loss, and you'll also see that described as a habitual aborter. That's kind of an older term. Now, the risk of miscarriage after having one miscarriage is about 20 to 25%, which if you remember back, that's about the baseline risk. So having one miscarriage really doesn't elevate your risk. Now, the risk of miscarriage after having 2 miscarriages ups it just a little bit, 25 to 30%, and after 3 is about 30 to 35%. So even after having 3 miscarriages, your chance of having a miscarriage the next pregnancy is only about 1 in 3. Etiologies of recurrent pregnancy loss are multiple, and oftentimes, once again, the diagnosis is not clear and there's no known etiology. But of the known etiologies, there are chromosomal disorders of the parents, maternal systemic disease, maternal anatomic defects and infection. About 15% of the time, these are due to the antiphospholipid syndrome, which is basically theorized to be an immune response that puts the body in a little bit more of a hypercoagulable state. And there's also such a thing called a luteal phase defect, and that's based on progesterone levels. That's not real clear. Some believe that that's an etiology of recurrent pregnancy loss, and some think that it is not. So when we do the evaluation of the patient with recurrent pregnancy loss, oftentimes we will actually start the workup if they've had 2 miscarriages, even though technically the diagnosis doesn't occur until you've had 3. We'll do a karyotype analysis of both parents, both the mom and the dad. If we've had a chance to do a DNC on a miscarriage, we'll actually do a chromosome analysis of that tissue. Oftentimes they'll present to you after having this history, but if you know that going into it, it's nice to have the chromosome analysis to know why that particular pregnancy miscarried. A hysterosalpingogram, it's called an HSG, which is an X-ray dye test, looking in the uterus, looking at the uterine cavity as well as the opening of the fallopian tubes. Or similarly, you can use a saline infusion sonogram, basically an ultrasound where you squirt sterile saline or sterile water into the uterus. Basically, it rules out any anatomic defects of the lining of the uterus. We also do some serum testing for thyroid disorder, diabetes, and a hypercoagulable syndrome or antiphospholipid syndrome. Other considerations, we'll consider checking progesterone, we'll do cultures of the endometrial lining, or we'll do an endometrial biopsy. But, as we mentioned before, about 30 to 50% of the time we will not find a cause for the recurrent pregnancy loss. Treatment. So basically, treatment will be based on the etiology that we found. If we have an anatomic defect, we'll try to surgically correct that. If we have a hypercoagulable state, we'll use anticoagulation, whether that's just simple as taking a baby aspirin or regular aspirin. Use of heparin or Lovenox, which is a low molecular weight heparin during the pregnancy. Sometimes we'll use a donor egg or sperm if we feel like that's the cause, or we'll administer progesterone if we feel like there's a progesterone or luteal phase defect. About 2/3 of the time, no matter what we do, a successful pregnancy will follow.
It's time for the end of session quiz. I want you to pause the video, answer all the questions in the end of session quiz, and then restart the video, and then we'll go over the answers together. All right, we're back, and now it's time for our end of session quiz. Let's get started. What are the signs and symptoms of an ectopic pregnancy? Important to know this stuff. Abdominal or pelvic pain, vaginal bleeding, pregnancy symptoms, abnormal rise in beta-HCG levels, and abnormal ultrasound findings. But sometimes you can have almost none of those and still have ectopic pregnancy. Next question. What are classic lab and ultrasound findings that suggest an ectopic pregnancy? So we've talked about this before, beta-HCG greater than 1500 and no intrauterine pregnancy on ultrasound. Next question. Match the type of spontaneous abortion with its definition. So we're going to go through all these right here. So first we have complete. Complete is a complete expulsion of all products of conception before 20 weeks of gestation. Next we have incomplete, and incomplete is partial expulsion of some of the products of conception before 20 weeks. Next is inevitable. Inevitable is no expulsion of the products of conception, but you have vaginal bleeding and a dilated cervix. Dilated cervix is the key phrase there. Next we have threatened, and this is any vaginal bleeding before 20 weeks, relatively common. And then we have missed, and don't be fooled. Sometimes people will miss this one, no pun intended, but missed makes you think, oh gosh, they might have had abortion, but it didn't happen. Well, that's not the case. Missed just means that there's already a death of the fetus before 20 weeks with retention of the products of conception. So that's where you could miss that on a test, is you think missed in your brain is, well, we've made it past this miscarriage situation, now we're safe. It's the complete opposite of that. It's just that you actually have the death of the fetus, it's just nothing's come out yet. Next question. What is the most common cause of spontaneous abortions? The most common cause is chromosomal abnormalities. Next question. What are the risk factors associated with an incompetent cervix? Well, patients who have had prior cervical surgery, so if they've had a cone or a LEEP procedure, most likely those are for things like cervical cancer or dysplasia, and they've had to have treatment for that. Prior cervical trauma, if they've had a delivery in the past and they had a major cervical tear or something like that. Uterine abnormalities, if they've been exposed to DES, though that is very uncommon now unless you have someone much, much older. But those are the three major ones. Next question. In order to be diagnosed with recurrent pregnancy loss, how many miscarriages must a patient have? The answer to that is 3. Next question. Which prostaglandin is used to cause uterine contractions in order to deliver a spontaneously aborted fetus? So if you have a patient who has a miscarriage, we need to get the products of conception out. What do? Well, we can use misoprostol, which is a prostaglandin. It's going to cause uterine contractions and help that situation out. Next question. What is the appropriate treatment for an unstable patient with an ectopic pregnancy? Well, the answer to that is immediate surgery by laparotomy or laparoscopy. So you don't mess around with an ectopic pregnancy. It's potentially lethal. So in that situation, you don't wait around. You don't give methotrexate. You don't follow serial beta HCGs. You go in for surgery and you do what needs to be done. Next question. All Rh negative mothers who deliver or have any form of bleeding should receive what? The answer to that, RhoGAM. It's not going to cause a problem with this pregnancy. It'll cause a problem for the next pregnancy. You don't want mom's antibodies to fight against the Rh status of the next baby. Next question. A 24-year-old patient at 20 weeks gestation is diagnosed with incompetent cervix. What is the treatment? So this is what we would call a pre-viable pregnancy at 20 weeks. So what do? We do bed rest. We do Trendelenburg position. We're trying to get pressure off of that cervix. And then you can do a rescue cerclage. So you can go in there and you can tie that cervix together as best you can. And then it's basically just hoping at that point. And if you get further along in the process, it becomes a viable pregnancy. Then potentially you can add steroids to the mix to try to mature those fetal lungs and then have a healthy baby when it comes out. All right, so that's going to end our end of session quiz. That's going to end our lecture for today. I hope you learned something and good luck studying.